I'll start off our afternoon with a talk on prognostication. And those of you that are senior residents may have seen an earlier version of this. We think it's really valuable for you. And so I adapt it each year so that we can share with you some of the pearls and some of the important knowledge for you all as part of your core medicine education. About myself, I do palliative care. I don't practice geriatrics, although I certainly am surrounded by wonderful geriatricians in the department. And I work both at Mount Sinai Morningside and Mount Sinai Hospital. So I switch back and forth between sites. And I hope to get to work with a lot of you during my time at Morningside. So some objectives for the talk. You won't leave this talk being experts and having a crystal ball. And I will hope to convey to you that none of us are very good at this, unfortunately. But I hope that you will all recognize the importance of prognostication and making a good effort to prognosticate. Describe a few approaches to help you estimate your prognosis and feeling more confident in those approaches. And then also with an eye on identifying patients that might be hospice eligible. We miss a lot of patients that could qualify for palliative care and for hospice services. And finally, to think about some communication techniques to talk about this subject with your patients. So whenever I had a lecture during residency, I always wanted to know, is this going to be on my boards? And this will be on your boards. This comes from the American Board of Internal Medicine certification blueprint. You will see there down in green that determining prognosis is part of your board's exam. I think it's important way beyond that. So prognosis, we believe, is important because people value things differently and they make different choices depending on how much time they have left. There are psychological studies that prove that. Knowledge is power. Having well-informed patients help us to make choices together and shared decision making about important things like where is the best place to take care of this patient? What are the treatment preferences? How invasive are the treatments going to be? Helping to not overutilize acute services, critical care beds. And I think with COVID, we've been thinking about this more and more, how these services are utilized. Making decisions about what treatments to pursue, and then also just allowing patients and their loved ones to have a normal grieving process if that's appropriate for where they're at in their disease course. We do know that people have different individual and cultural preferences about talking about this. So while I encourage you to talk about this, we never do that without having an invitation from the patient and the family before we delve into things that might be hard to hear. The Journal of Clinical Oncology a few years back published this. Patients with advanced cancer who discussed their prognosis with their physicians had more realistic expectations about their life expectancy. And it didn't hurt their feelings. It didn't damage their emotional well-being. Although people do have an emotional response to new information, this did not harm their relationship with their doctors. Those same patients, when it did come to the end of life, they were more likely to prefer comfort care over aggressive treatment in the end of their life. So it occurred to me that I don't know if all of you are old enough to remember this toy. This is a magic 8-ball. This was something that I played with as a kid. This comes to mind when so I read through charts and I just tried to list some words about prognosis that I've seen in charts from other specialist, but some vague descriptors you can see. So I don't really know what's worse. Is a poor prognosis worse than a guarded prognosis? How about grim or dismal or abysmal? I forgot that one on this list. The takeaway point for this slide is, I don't know if these words really help us. I think it might help to point us in the direction that maybe we need to talk about what's happening with the big picture. But we in palliative care, we try to give a range of time whenever we can. We find this to be more helpful when it comes to making choices and helping people to plan and prepare. So we always give a range of time because we're not a magic 8-ball, or we're not a crystal ball. So we give a range of time anywhere from minutes to hours, hours to days, days to weeks, weeks to months, months to years. Just to go over a couple of cases, and these cases, I really hope to illustrate some ways, some concrete ways that prognosis can help you make clinical decisions and share decision-making with your patients. Let me see, I'm having trouble seeing. I was going to call for a volunteer. Chiefs, can you perhaps call on somebody who looks like they might want to read this first case?
Yeah, I see James. He's the first one on the screen, so I think we can volunteer him.
Yeah, I was buzzing to read that.
Thank you for helping. I never like doing this alone. It gets lonely.
So an 89-year-old male residing at home with his daughter, 10-year history of Alzheimer's disease, presents with a temperature of 38.3 centigrade, productive cough, respiratory rate of 28. Nurses report that for the past 6 months, he's been coughing at breakfast, having trouble swallowing. He has profound memory deficits, no longer recognizes his daughter, who is his healthcare proxy. He's bedbound, is able to mumble a couple of words, and is unable to perform any ADLs. The daughter is overwhelmed at home and looking for additional support to keep dad at home.
Thank you, James. So you've all seen this patient, right? I know that you have by this point in your residency. So if I get called, this is what I'm going to think about. Your daughter is overwhelmed, so something's going to have to change. Can this patient be eligible for more services with a different focus, which would be hospice services? And if the prognosis is less than 6 months, we can evaluate and refer that patient to hospice. So that is case number one. And how do I figure that out? I look to my prognostication tool for dementia to find out if the patient has end-stage dementia and would therefore qualify for hospice. And the FAST scale, which I'll show you on a later slide, is my tool, and it's also the tool that the hospice uses. So this patient meets the criteria for the FAST scale 7A, which is just past the threshold between moderately advanced dementia and severe dementia. Patients in this category, they have a prognosis of weeks to months, or in other words, under 6 months, and those patients qualify for hospice. Case number one continued. Can I have another volunteer? Or we use the word voluntel in our department, which is a nice way of telling somebody to help out.
Yeah. Who do I see? Rebecca, we love hearing your voice.
So patient responds well to pneumonia treatment and regains ability to take small amounts of food with meals, but is clearly not taking enough PO to sustain nutritional needs. PEG will not be pursued. Patient is now less mobile and has an enlarging sacral ulcer requiring daily wound care associated with pain requiring opioids. Prognosis is days to weeks. Patient qualifies for facility-based hospice, i.e. hospice residence or SNF with hospice.
Thank you so much. So yeah, I know you've seen this happening too. So we've called Hillary Bogert and she's come and she's done the swallow evaluation. It didn't go well. And we have that conversation, which we often have about the PEG. So we know that PEGs are not recommended in advanced dementia, in particular when there's aspiration. They do not prevent aspiration. They don't help with mortality benefit, and they don't help with quality of life. So fortunately, it seems like that recommendation has been accepted. And because the inability to take nutrition, which is the way that patients die from dementia, this is the natural history of dementia, is that they stop eating. So this patient now has a prognosis of days to weeks based on the lack of nutritional intake. That is how long someone can survive without nutritional intake. In New York, just talking about what is a hospice residence, it's basically, it's one of the levels of hospice care. The lowest level is routine hospice care, which takes place at home. And hospice residence is basically the same thing as home hospice. It's just in the situation where home doesn't have 24-hour caregivers. So that's where a hospice residence comes in. And New York only has one right now. Unfortunately, it really is unfortunate, but there's one called block residence. And more often patients that go with need a hospice residence, they do end up back in our SNFs or our skilled nursing facilities with hospice services there. So we can see again how prognosis helped us make that decision. And last event with this patient, unfortunately, he has another aspiration event, and now he's become tunded with Cheyne-Stokes respirations. And we know that this breathing pattern in the right setting, in the setting of a terminal illness, this is highly sensitive and specific for being within the last 24 to 48 hours of life. So we now believe that this patient has a prognosis of hours to days, and that actually opens up a different site of care. In particular, when it's not safe to move him to the nursing home anymore, we could evaluate him for GIP hospice, which means general inpatient hospice, which we can convert him to in the hospital. And some of you have cared for these patients alongside of us. GIP hospice, as an FYI, this is like the critical care. This is the highest level of hospice that has to be delivered in a hospital setting or an inpatient hospice. So you can see how important that case. I'll do case number 2. This is a little shorter. So this is a patient with metastatic cancer faced with the decision whether to continue with his palliative chemotherapy. He's been having some side effects, including severe nausea and fatigue. He's finding it difficult from those side effects to actually enjoy the time that he has left with his grandkids. The oncologist has been very helpful and is able to tell us that the prognosis without the chemotherapy would be about 3 months. But with further chemo could be 6 to 8 months. In that situation, the patient makes his own judgment call that to him it is worth it to continue with the chemo to potentially gain those extra 3 to 5 months. But if the oncologist, hypothetically speaking, had said that further chemo would only add potentially 1 more month to survival time, that might tip the scales where the patient can make a choice that it's not worth it to pursue more chemo with those side effects. So this is the situation of the patient making different choices for themselves depending on how much time is left. In the shorter time, he's going to opt to spend more quality time with his grandkids and feel well as long as he can. And the last case example I'll show you, just to convince you of why prognostication can be helpful. A patient with end-stage COPD now has a new onset of major depression with fatigue. In the setting of just how weak and how crummy he feels from the COPD, he has developed major depression. If his prognosis is weeks to months, we do feel strongly, we in palliative care, but in general, it's recommended to treat major depressive disorder with a medication and with therapy if you can, even if the patient has a terminal prognosis. We don't feel that it is natural to be depressed just because you have a short prognosis. So we do recommend treating that to help with quality of life. If the prognosis is a little on the longer in palliative care terms, weeks to months, it would justify starting an SSRI, which is you all know is the first line treatment for major depressive disorder, but can take 2 to 4 weeks or even longer to see any benefit from that. So if your patient isn't going to live that long, you wouldn't make that choice. If the prognosis is shorter, in palliative care, we use medications differently to get more of a short-term and immediate effect. And methylphenidate, which is Ritalin, is a great example of that, to give patients just a boost of energy to try and enjoy the short time that they might have left. One example of a case where I've used methylphenidate is a patient who really just felt incredibly fatigued and down and anhedonic, and had no interest in connecting with his children, and wanted to perk himself up for a couple of visits that they were planning to the inpatient hospice unit. And Ritalin is administered in the morning and then a little bit of a smaller dose in the afternoon. You cannot use this long term because you'll actually lose that uplifting effect. But this is something that you can find in the palliative care literature, and this is an accepted first line treatment for major depression in a very short prognosis. So hopefully I've convinced you that there's a lot of value. And next I will move on to how do we do this. And first I'll say again, we don't do this great. Physicians, including palliative care physicians, are over large studies were shown not to be very accurate, even when we are trying hard. So some of the studies show a range of accuracy between 23% to 78%. That's almost like flipping a coin. However, physicians are a little more accurate than nurses, especially when the prognosis is longer, like in the weeks to months range. I think that is probably because we think more about how to access these prognostication tools and go to the evidence and really look to the literature to make an educated guess. When it comes to shorter survival times, nurses are shown to be more accurate. And I think that is because they are more attuned to those physical signs and symptoms, which I'll go through a little later, that are really accurate at predicting a short survival within a day or two. Why is this so hard? So a few reasons come to my mind. This is not an exact science. We just don't have the data. It's, for a lot of reasons, it's hard to have randomized control trials. It's hard to have large populations that are willing and able to be enrolled in studies about this. And people's constellations of diseases, people when they're dying, they typically don't just have one disease, they often have many comorbidities. And so it's hard to prognosticate for one particular disease when things can kind of become very chaotic near the end of life, where there's everything's falling apart sometimes. I also think that we're not that great at this because it's not standardized part of our medical education, or it's not highlighted in our medical education. We aren't taught to diagnose dying. I didn't learn to think about dying as something that could be diagnosed until I trained in palliative care. Perhaps we do not like to think about this in medicine. Most of us become doctors because we want to help people live. And I think that there are some deep, deep philosophical reasons why we don't think about death and prognosis in a very systematic way. And then I mentioned that patients don't read the textbook, so everybody's disease course is unique in certain ways. And then there's physician bias. And we have studies that show us that, in particular, physicians that have been caring for patients for a longer time are more likely to overestimate the prognosis, because we don't want our patients to die. We want to do a good job helping them to survive, and we get attached to them. So we overestimate even more for people that we've known longer. Just to point this out, fun fact, there's no ICD-10 code for dying or for active dying, despite the fact that we have these ridiculously specific ICD-10 codes that you see below. So everybody dies, right? Everybody, 100% of us. And I'm not sure what percent of people get sucked into a jet engine at one point in their lives or get pecked by a turkey, but there you have it. So, you know, a fun way to think, not fun, but a way that I think about this is I wonder why we don't have a diagnostic code for that. Perhaps it's not something that we really want to acknowledge. That's my theory anyway. Okay, so we can though overcome some of these prognostication challenges, and we can get better at it and more confident in our ability to talk about it. The closer we get to death, the prognosis, it gets easier. It does, because you can start to actually see the organ failure, the deterioration actually happening in front of you. So when dying becomes less of an abstract concept, we do get more accurate and you're nearer to the end of life. The basic survival functions can start to come to factor in, things like eating and drinking. And I will just comment that it's not always on our radar when we're taking care of very sick patients. I do find myself pointing out or observing to teams when I'm called for a consult that this patient's not eating and drinking, and do we think that's limiting the prognosis? So just highlighting that it's not always on everybody's radar, but it certainly does limit the prognosis. Some other examples, of course, if you're doing life support, if you're doing critical care in the ICU, if you were to stop those things, you would end up with a very short prognosis, probably in the hours to days range in most cases. So that can be, I mean, not to be a downer, but that can be helpful when it comes to getting more accurate prognosis. The surprise question, functional status first, performance status, how much can a person do for themselves, especially in cancer-related conditions. This is very high yield piece of information. I'll go into more depth about that. And then the surprise question is another simple tool. Would I be surprised if this patient were to die in the next year? That is a validated question that is shown to be accurate in predicting survival. And then another approach is learning the language, so to speak, of the specialist that you're dealing with. So when I'm talking to an oncologist about prognosis, I'm going to use ECOG because I know that ECOG was a scale that was created by a group of oncologists. So when we speak the same language together, it can be easier to get people on the same page and get a consensus about a prognosis. And I mentioned that another approach that can help us is to look for some of the signs of impending death. 8 physical signs that are highly diagnostic. I listed them here: non-reactive pupils, decreased response to verbal stimuli, decreased response to visual stimuli, inability to close eyelids, drooping of the nasolabial fold, hyperextension of the neck, grunting of vocal cords, or upper GI bleed. So how does this play out for me typically in a clinical scenario? If I get called for a consult and maybe there's just sort of that general prognosis, things aren't looking good, and I walk into the room, there are some times when I really walk into the room and you can get a gestalt right away. This is a dying patient, and that gestalt, I think a lot of it comes from seeing some of these highly specific signs immediately on a physical exam, especially if you're attuned and you're looking for these things when you walk into a room. Some other changes that aren't specifically mentioned on here, there are the changing respiratory patterns, agonal breathing, Cheyne-Stokes breathing, mottled skin, cool skin, decreased urine output. These are some of the things when you're getting very close to the end of life. So the surprise question, again, would I be surprised if this patient died within the next year? When would we use this question? We can use it a lot of ways. You can use it individually when you're evaluating a patient and you want to try to determine if they're hospice eligible, for example. This question is used here at Mount Sinai Morningside, actually. It's used with the orthopedic surgery, the trauma surgery teams as part of their HIP alert pathway. So if they have an elderly patient or a patient with a terminal illness coming in with a hip fracture, they have a workflow and a flow chart that prompts them to ask themselves the surprise question as part of their initial evaluation. If the answer to this is no, I wouldn't be surprised, they call palliative care and they go over the case and figure out if it's worth a consult. So it can be used as sort of a trigger or a screening question. And you can see here that meta-analysis of 26 papers with 25,000 predictions of survival had a pretty good accuracy, 74.8%. And this is better than the range that I showed you before of studies of just physicians trying to prognosticate on their own without a screening tool. So pretty decent accuracy for one simple question. So performance or functional status. This is something that, in particular with cancer patients, if I ask people this when they rotate with me, if you have a cancer patient and you want to figure out their prognosis and you only have one question to ask them, what question would it be? And the answer that I like to hear is a question about functional status, or basically how much can you do for yourself? And I'm going to show you why. So this graph is functional status on the y-axis and time on the x-axis. And it's been sort of sketched out for a few different disease processes. So you guys can see my pointer when I do that, right? So everybody starts out with 100% or high performance status. When we're normal and healthy, we can do a lot for ourselves. In the case of the red line, which is sudden death, you are going along, living your normal life, doing your thing, and then you die suddenly. So there's no deterioration in your functional status until you die. In the setting of cancer, going along with pretty good 100% functional status, and then as your disease progresses, you have a sort of gradual downsloping, but that accelerating loss of function until you pass away. And that is fairly predictable, especially for most cancer types, honestly, especially for solid tumor cancers. Looking at this little wiggly up and down, so this is more prognostically challenging, but for advanced heart disease like heart failure or lung disease, and I also would add liver disease to this, the pattern is a little different. So people have, overall, they have a downsloping in their functional status over the long term, but in between, there are these intermittent periods where they have exacerbations, where their disease becomes uncompensated. They have a hospital admission for a heart failure exacerbation, for example, and then they get treated and they get a little better. Maybe they don't get quite as better as they were before, but maybe they do for a while. They get better. And the prognostic challenge here is, how do you know when you are in this acute exacerbation versus when you're at the end of life? And that can be incredibly challenging for us as clinicians and also for our patients. And then the yellow sketch here is for dementia. And there are different dementia types. It doesn't go into that degree of specificity, but either you're going to have the Alzheimer's type, which kind of like sloping down over time. You lose your functional status very gradually, versus vascular type dementia, where you might lose your functional status stepwise. So that's actually a little more what this graph looks like, where it's sort of, you have some kind of vascular event and you lose some function, and then you're at a new baseline, which is lower. And then you have another vascular event, another little stroke, and there you go. So just a little, I like that sort of infographic to as a teaching point for trainees, but I also sometimes even use this for certain patients and families that are savvy and really want this level of detail. So let's go into detail about cancer first. I mentioned that performance status is the single most predictive factor for prognosis. How much can a patient do for themselves, which is a good reflection of their activity level and their energy level. Patients with solid tumors typically lose 70% of their functional ability in the last 3 months of life. And so there are two scales that tell us the exact same thing. Karnofsky index, we use more in palliative care and geriatrics. ECOG is what the oncologists use. I'm going to show you on the next slide that they actually, one of the next slides, they actually line up. They tell us the same thing. So Karnofsky basically starts at 100%, which is your normal. You have no complaints. You can do everything for yourself. You don't need any help with dressing or bathing or doing any of your ADLs, versus ECOG, which starts at 0. And that's the same thing as Karnofsky 100. So Karnofsky 100% is good and 0% is deceased. On ECOG, it's the opposite. 0 is normal and 5 is deceased. And so then you have your scale in between. So let me backtrack for just one moment. So the scale is telling us about people's ability to do their own self-care, basically. And the one question that is the best question to ask, I'll tell you why it's the best in a second, but basically is, how much of your time do you spend in a chair or lying down? If it's more than 50% of the time, especially if it's been getting worse over time, you can roughly estimate the prognosis to be 3 months or less. There are large studies that show us that, just statistically, looking at large numbers of patients. So greater than 50% of the time in bed or in a chair in the setting of cancer, prognosis is 3 months or less. The more symptom burden you have from your cancer, the shorter the survival time is. I showed you guys this. Just one important milestone, I guess, on this ECOG scale in particular. For patients that have an ECOG of either 3 or 4, so that means they're capable of only limited self-care, confined to a bed or chair for more than 50% of the day. So that's a question that I mentioned on the prior slide. They are not recommended in most cases. They're not recommended to have further disease-directed treatment with chemotherapy. At that stage of functional status, more treatment is thought to be more toxic and cause more harm than good. And that's a really rough sort of milestone, but you can use that as a conversation starter with an oncologist, for example. If you're trying to figure out whether a patient is able to get more chemo, if you were to mention to the outpatient oncologist that you're treating their patient for an inpatient hospitalization, and you've taken care of the acute problems, and now here they are left with an ECOG of 3 or 4, that's going to give that oncologist a red flag and be able to make them pretty well informed about just giving even a hypothetical recommendation if they can provide more chemo. So how do we know that spending more than half of the day in bed or a chair means less than 3 months? This is a large study from the Journal of Oncology Practice looking at 1,600 cancer patients and trying to estimate prognosis using the performance status. For patients with an ECOG of 4, so that means they're completely disabled and they can't do any of their self-care. That's the worst functional status that you can have without being dead. So you can't do anything for yourself. At that point, the estimated median survival was approximately 25 days. And then for each level you go below that, so ECOG, each level you go below it, you have basically twice the amount of time. So an ECOG of 3 has a median survival of 50 days, ECOG of 2, median survival of 100 days, and ECOG of 1, 200 days. I found that very surprising, actually, when I stopped to think about an ECOG of 2 or 1, let's just say 1. You are restricted in, sorry, screen is covered, strenuous activity, but you can walk, you can go out and about, you can carry out some work. You have 200 days perhaps of survival. And then when you cross to an ECOG of 2, where you're still ambulatory, you can still do all of your self-care, but you can't work anymore. So when a person becomes unable to work as a result of their cancer progression, I was very surprised that that puts the median survival at about 100 days, because that's fairly short. That's basically almost short enough to qualify for, it's short enough to qualify for hospice. So I found that very noteworthy. Okay. I've mapped this out. One of my attendings did this for me when I was in my fellowship, but just again, another way of looking at ECOG and progression of loss of functional status leading up to death. How would I use this? So you have your ECOG of 0 when you have 100% functioning, but then you sort of accelerate 1, 2, 3, 4, 5. And when you are at the ECOG 3 mark, that is the week's range of prognosis. So I find this visually helpful to remind me of patients that are in front of me that perhaps are spending more than 50% of their day in bed or a chair, that this is where they're at on this kind of graph here. And then there are some other factors besides performance status that always tip me off, and it makes me want to delve a little more if I see a patient that has malignant hypercalcemia. It's a common cause of hospitalization for cancer patients, especially, it's kind of par for the course in breast cancer or myeloma, but if you see malignant hypercalcemia in any other cancer types, that portends a very poor prognosis in the weeks range. So some of these other things might tip you off: brain metastases, malignant ascites, malignant bowel obstructions, generally all signify that a patient might be eligible for hospice. So a little more about dementia. This was covered in the earlier cases. End stage, the end stage of dementia is what we define as when a patient has lost their ability to do all of their self-care. Essentially, they aren't able to speak anymore. They stop eating and drinking. Sometimes they have aspiration pneumonias, and they're also incontinent. These declines can be, in this setting, oftentimes we have acute problems that can make this whole situation worse. UTIs, aspiration pneumonia, end-stage dementia patients are very high risk for those complications, and we see them a lot in the hospital on our geriatric service. In end-stage dementia, people are not very well prepared for end-stage dementia in the outpatient setting for a number of reasons. There's not always a lot of education about what the very end of the dementia course looks like. And I think that is why when we see these patients in the hospital, it can be so challenging to have those discussions about hospice care or to have the discussion about whether to do a PEG tube, because it is very difficult to prepare for this in the outpatient setting. Most patients and families do understand that dementia is progressive. There's not a lot of awareness, in my experience, there's not a lot of awareness of how the very end looks. So we do a lot of that education in the hospital. Mortality in end-stage dementia typically caused from not eating or from complications like aspiration pneumonia. When patients don't eat in the setting of dementia, we do counsel families that they're not starving. There are metabolic processes that change. There are hormones that are released to actually suppress the hunger response. And so we do, to get at the emotional reaction of the family, we do counsel them that starvation is not what's happening, but this is the natural history of dementia. Something noteworthy on this slide is that with a new hip fracture in the setting of end-stage dementia, mortality is 55% within 6 months. And that was actually published by Sean Morrison, who's our department chair and the husband of Diane Meyer, who you're going to meet later. But very high mortality for a hip fracture in the setting of dementia, greater than 55%. Patients are eligible for hospice when they have advanced dementia. This is the functional assessment staging for dementia, and I'll just point out 7A, which is the line for hospice eligibility. By the time you reach 7A, you've lost your functioning and your organizational capacity. You can't do any of your ADLs, and you've now lost the ability to speak, except for just a very few words. So less than 6 words defines advanced dementia. And this is what we use, and this is what the hospice agencies all use. So helpful thing to have in your wheelhouse. You definitely don't need to memorize it, but you can always look that up if you are trying to figure out hospice eligibility for dementia. For stroke, just briefly, so shifting gears here, I'm pulling out this little diagram again, and sorry, I made my little chicken scratch on here, but the purple line is the course of functional status after a stroke. Oops, go back. I added this because I have at least 3 different outcomes that can happen after a stroke. So you're starting out with all of your functioning, then you have a stroke and you become pretty disabled immediately after the stroke. It keeps doing that. Pretty disabled. Then if all goes well, you can get to rehabilitation, and you can either rehabilitate pretty close to your prior baseline, maybe regain all of your functioning, which would look something like this, versus maybe some new baseline that is less functioning than you were before. Or unfortunately for some people, they aren't able to recover after a stroke because of too many complications, and maybe they don't make it to rehab, especially some of our elderly patients. And then the functional status could be lost. So how the heck am I going to use that to talk to a family member and counsel them about prognosis? This is an uncertain prognosis. And as you might imagine, and I'm sure you have been through this, but when the prognosis is uncertain, it makes it harder to have that conversation about where things are going and what's going to happen to that patient. There is a framework that makes it a little easier, which we call best case, best worst scenario, best case, worst case. I also add most likely scenario sometimes. So this is definitely not an exact science, but with a team of generalists and specialists that are treating that patient, and with your neurologist who's evaluating them after their stroke, you can put together some kind of information about what is the best case for recovery, what is the worst case, and what do we kind of think is the most likely. It may not seem like a lot of information when you're putting that story together and imagining what the best case, worst case is. It might not feel very hard science or very, very exact, but I can assure you that that information can still be incredibly helpful to families. even just the information that this person's going to rehab, they have to go to rehab in order to get better at all. And the more time they spend in this hospital not getting to rehab, that points us more toward the worst case scenario. Patients that have had a bad stroke and might require a trach and a peg. Just sharing the information that the most likely scenario is going to involve long-term institutionalized care. That can be a surprise to people when they hear that their loved one isn't going to go home necessarily. They're not going home for a long time. So just giving as much as we can about these different scenarios is better than nothing, even when things are uncertain. And I encourage you to think about using this best case, worst case, most likely scenario. There's no one right way of doing that, but it should involve a discussion amongst all the team members. If none of those outcomes are going to provide an acceptable quality of life, acceptable as defined by the patient and their values and their family, if none of them are acceptable, that is the time to talk about either withdrawing care, withdrawing life-sustaining care, and moving to comfort measures, or not pursuing aggressive treatments like a trach and a peg at that point. Because if there's nothing that's acceptable of the best, worst case, or most likely, then it doesn't make sense to pursue more treatment. So that is how that tool is used. I know I'm getting a little short on time, and I want to leave time for a couple questions, so I might not spend a lot of time on heart failure and liver disease, but I showed you the trajectory of heart failure can be up and down, which makes it very challenging. For pulmonary disease, one thing to know is that there's no great way of determining whether someone has 6 months or less. There are hospice criteria, though, that are readily able to be looked up. So you can look up the criteria for a hospice admission for COPD, things like core pulmonale, low PO2, and some other sort of nutritional indicators can qualify a patient for hospice. But a study looked at these criteria, and half of the patients out-survived their hospice prognosis. So again, that's not really better than flipping a coin, but you can utilize them at least to get more services for patients sometimes. For outpatients versus hospitalized patients, there are a couple of other things I want you to know about the Bode scale, which factors in BMI, exercise capacity, and subjective dyspnea. So that helps to predict survival over 1 to 3 years in the outpatient setting. And then in the inpatient setting, patients that require mechanical ventilation have a very high in-hospital mortality at about 25%. Liver disease, again, like heart failure and pulmonary disease, has exacerbations. One important pearl here, I think, is that even though we have some really great, we do have some tools that we can use to determine that someone has a high mortality. These patients are particularly challenging to get palliative care access. And that is because the sicker you get, the greater your chance is of getting a liver transplant. So that is a barrier, actually, because that means that some of our sickest patients, because there's that hope of transplant, that they don't get the services that palliative care can offer, such as symptom management, advanced care planning, hoping for the best, preparing for the worst. So that being said, if you look to your MELD score, you can see that MELD correlates with different mortality the higher the MELD score, and your child PU score is another way of determining the chance of survival at the 1-year mark. Renal disease, if you withdraw dialysis, the prognosis is very short, days to weeks. Interestingly, for end-stage renal disease patients who have never started dialysis, they actually have a prognosis that's a bit longer. So there is a difference between somebody who's been on dialysis and taking it away versus somebody with CKD5 who should start dialysis unless shared decision-making, leads to them not starting dialysis. And then their prognosis is more in the months range. Other comorbidities, of course, will change the prognosis. And I included here the Charlson Comorbidity Index. Many of you have probably seen this, but this is a scale looking at common medical comorbidities and determining a yearly mortality rate for somebody that has different combinations of comorbidities. And then there are some online tools. There are a lot of different ones. UCSF has collated and organized together a lot of different online prognostication tools called ePrognosis from UCSF. So you can look around in there. This is actually a graphic that they made of a bunch of their different prognostic tools, and they're rating the quality of them. So on the x-axis here, the higher the quality, they put the better quality prognostic indicators up higher. So you can kind of click on, and I picked Walter 1-year index as an example for hospitalized patients, because that's where many of us are seeing our patients. They ask you a lot of different things about their performance status, your gestalt of their survival. So you can play around with these tools just to help you frame your thinking. And most importantly, the most important thing isn't getting this right 100% of the time. I would argue that the most important tool is the way that we frame our conversation around prognosis. So when a patient asks me, am I dying? How long do I have? Instead of panicking, I invite you all to take this question as an opportunity, really, to just have a back and forth and have a dialogue about what the future might look like, and use that conversation and the tools that I showed you in earlier slides, use them together to just have a conversation and shed some light on things that perhaps many other doctors or specialists haven't been able to talk to this patient about. How do we talk about it? So CAPSI is a great online resource. Diane Meyer, who you'll meet shortly, she runs CAPSI. She founded CAPSI, but Center to Advanced Palliative Care has a lot of great self-directed learning. You all have free accounts with your Mount Sinai email address. But the basic sequence, when you discuss prognosis, these are some of the basics of how you get through the conversation in what order. First, you're going to assess what information your patient wants. You need to get an invitation before you tell them something horrible. So find out how much they want to know. If they don't want to know anything, then you stop right there. If they want more information, then you're going to get their permission to discuss their prognosis, to discuss how much time might be left. Next, you're going to give them a clear assessment of the prognosis using very simple terms and not sugarcoating, but very simple and straightforward. And then the last thing you're going to do is help them to cope with what you've just told them. So you need to help them to cope by providing emotional support. You can refer to get more help with that if you need palliative care support, or if you need chaplain support, and to help with family coping mechanisms too. But that's the basic order of the conversation. Some helpful phrases to get comfortable with. Tell me how you spend your day. We get patients' whole medical history in the hospital, but we don't always ask just something simple like, what do you do in a normal day? Walk me through your normal day. So try that question out. If it's not something that you're asking routinely, you can get a ton of information for you're going outside of your usual HPI, but just asking that one question, what do you do each day? That can tell you a lot about functional status. Assessing understanding. Has anyone talked to you about what to expect? What have your other doctors told you about your condition? Do you have a sense of how much time is left? Would you like to talk about that? And then practicing. I can't give you an exact range of time, but I can give you a range, my best estimate, which is anywhere from weeks to months. And then the last thing can be very, very hard to say, but if someone asks you if they're dying, and your clinical assessment and your team, your team's assessment is that they are dying, and then it's important to respond to that question with the truth, which is based on what I see. Unfortunately, I believe that you are dying. And just as a reminder, no one of us has to make that call alone. That's why we work in teams. And it's incredibly important to have the whole team on the same page about the information that you're going to deliver, especially when it's tough information. So that is my talk. We've covered a lot of ground, and I look forward to rotating with you and maybe practicing some of these prognosis tools and some of this communication. Thanks for your attention. Are there any questions at all or any comments?
Hi, I have a quick question. Thank you for that talk. It was very interesting. I thought it was interesting that you mentioned that ortho includes that surprise question as part of their admission workflow for the hip. I've been in a lot of situations, either admitting to the floor or the ICU, where we're admitting a patient with either like a severe like comorbidity, or is very elderly and has had a clear like documentation of progressive decline over the past year or two, and palliative care was never involved. Do you think it would be practical for medicine to include like a surprise question in like our admission workflow, either based on some age cutoff or some kind of diagnosis?
I think that would be so helpful. Yeah, I invite you to think about how to actually do that. You can experiment doing that on your own, and that is true what you say is, and we see that a lot too, where patients, surprise, no pun intended, we can all be very surprised when we meet these patients in the ICU and we finally do get that consult and we look back over all of the things that have happened. And I know personally that our team is always, sort of surprised that we haven't been called about that patient and wish that we would have been called sooner. There are, this is not just specific to Mount Sinai Morningside. This happens everywhere in the world, which is that palliative care and or hospice are involved too late. This is just an ongoing struggle and a challenge. But there are many complicated reasons why we don't get that call. I think one reason is just a discomfort, just a little bit of a discomfort of, am I giving up on this patient by calling palliative care or calling hospice? And I think that having a tool like the surprise question as part of your routine assessment can remove that issue, because now it's not an issue of you personally making a judgment call, but you're using this validated tool. It's asking you, would you be surprised if the patient died? And that is a great way to empower you to bring that up with your attending, when you're on service. I think this patient would benefit from a palliative care consult. I reviewed the chart and we can see the declining functional status. And I do think that we should consider getting a palliative care consult. So I encourage you to think about, and we can think together about ways to even, sometimes we even add things into Epic pathways where things can become automatic triggers. But certainly when you're admitting your patient, you can use that tool. And from our standpoint in palliative care, it's never too early to call us. And sometimes you may call a consult and we may have a little bit of a dialogue about the timing of the consult. We're never upset that you called. We may work with you on figuring out the best timing for us to suddenly appear in the hospital, and we don't want to catch patients and families off guard either. But I do think that it's never really too early to call us and run by the case, and we can figure out together if that timing of the consult makes sense. Thank you for bringing that up. Other comments or other questions?
Feel free to unmute yourself and ask a question or have a comment, or put it in the chat. If nobody has a question, I actually had a question I want to ask. So my question is, especially with oncology in the past 10, 15 years, with advances in cancer-directed therapies, have you noticed that there's need for reassessment of the tools with improvements or with changes in life expectancy with these newer therapies? Or do you think that these therapies haven't really had enough benefit to ask or require an adjustment in the prognostication models?
Such a great point. Yeah, you are exactly right. And I think what you're talking about is immunotherapy, which tends to be much less toxic and can be tolerated for a much longer time than our traditional chemotherapy. So, right, yes. And there's not a new model yet that I am aware of. But what that means is that if you have a patient that's on immunotherapy, or where immunotherapy may be an option, it shouldn't hold you back from using the ECOG tool to open up that discussion with the oncologist. And I'm not going to have that information because I am not knowledgeable enough about all the different types of cancer to know what can be treated with immunotherapy. I simply don't know, and the oncologist would know. So continue to use that as a tool. That is a model that is widely regarded still and used as a tool. And then the oncologist may respond back to you by saying, oh, you're right, this is a high ECOG score, but what we're considering here is generally very well tolerated. And sometimes they may tell you that the prognosis is longer than you would have thought.